Yeah, thanks. Yeah, thanks for that. So my name is Mark Powell. I'm the CEO of ReachNeuro. We're a recent spin out from the University of Pittsburgh and Carnegie Mellon University in Pittsburgh, of course. And yeah, I'm excited to tell you a bit about what we've been up to. I want to start by describing a scenario that happens, unfortunately, a lot in the US, which is someone's going about their day-to-day life. They realize maybe their face feels a little weird or they have trouble speaking, maybe their arm is weak. Recognizing these as symptoms of stroke, they call 911, they're rushed to the hospital where doctors work to restore blood flow to the brain. This happens 800,000 times per year in the US alone. Once the patient kind of recovers from that surgery, wakes up, then they realize that they can't move their arm and hand. You can imagine this is really scary time for a lot of patients. And often they'll then go to physical therapy, say 6 months of physical therapy. And during that time, they will see some improvement, but not for everybody. A lot of patients get to a point where they can't use their arms still. They aren't in a functional state. And for those patients, unfortunately, there's really not that many options. So permanent impairment happens in about half of all stroke patients. And there's really no standard of care today for these individuals. They're kind of forced to look for other types of ways to work around their deficit. Maybe it's orthotics or other devices that help them get through their day-to-day life. And as you might suggest, we'll propose a solution to that. But first, I wanted to show you what I mean by motor impairment. So this is our first subject in the clinical trial that we've been running at the University of Pittsburgh. And she's very much in the chronic stroke phase. So this is actually 9 years after she's had her stroke. And this is what it looks like when she's trying to feed herself in this case. So you can see she's left arm impaired. She has difficulty grabbing the fork with enough strength to kind of push it into the food. And then in the second here, you'll see her try and bring it to her mouth and feed herself. And she has some range of motion issues in her wrist as well. So she can't supinate to actually feed herself. She's a good sport here, but day to day, she really can't use her left arm very much. So just to kind of dig into what's actually going on, in a healthy brain, one that has not had a stroke, the corticospinal tract is the portion of the brain that brings signals from the cortex, from the motor cortex, down to the spinal cord and ultimately out to the muscles to cause movement. In the case of stroke, though, damage to the corticospinal tract really correlates highly with someone who has motor or permanent deficit. But very rarely is that a complete transection of the corticospinal tract. So there's usually some fibers that remain, or the brain works out another pathway to be able to leverage, this same kind of pathway. And so, in general, it makes sense that to resolve this problem, you'd look to the brain and promote ways to grow back those connections. And there are people out there looking at doing just that. But I'll pose now an alternative option, which is to look into the spinal cord. The reason I say that is there's a really nice feature, conveniently, of the anatomy, which is that sensory afferents, so the neurons that bring sensory information from the periphery and ultimately up to your brain to sense things, also synapse directly on the same motor neurons that those corticospinal tract cells do that help produce movement. So what we can do is we can stimulate these sensory afferents as a way to modulate those motor neurons. And what we're doing essentially is increasing the motor neurons' responsiveness to a weaker signal that's coming from the brain. So the stroke damages the corticospinal tract, but there's still a few signals that are making their way down. And if we can get the nervous system respond better to those signals, then we can help restore movement. So this all sounds good on paper, but I'll show you what this actually looks like in person. So on the left, this is the same video I showed before. On the right, you'll see again this subject with the stimulation turned on, and these are seconds apart. So clearly, she's now able to use her arm, in this case, to feed herself. I do like to highlight as well the sensors on her arm. Those are just EMG sensors. So what we're actually developing is a fully implanted spinal cord stimulator, epidural stimulation, just like many of you are familiar with in this room. And so that kind of brings me to this slide to tell you a little bit about what we're actually doing here. So we implant 2 arrays of electrodes in the cervical spine, spanning C4 to T1. This is the part of the spinal cord that innervates the muscles of the arm and hand. And what's really nice about this area is that it's very well organized. So I can pick out which electrode I stimulate on and be very precise about the type of movement that we potentiate, which means we can be very targeted with our therapy to help someone with their individual deficit. The product itself would be a stimulator that many of the people in this room are familiar with. And in many ways, that's a really great thing because it means that neurosurgeons can implant these, right away. The one thing I'll mention, though, is that we're kind of building this on top of this platform, a way to program this better. So something that we really have to think a lot about is this sort of multi-dimensional problem where we have to be able to potentiate all the different joints that someone needs help with. And that's where our innovation is coming into this space. I'll also present some data from a recent publication that we just put out in Nature Medicine. This is the first 2 patients of that clinical study. And you can see from the stroke, the lesion diagram here, that both of them have pretty dramatically different stroke. But if we stimulate on, again, individual electrodes, you can't really see them in this picture, but there's separate electrodes for each of these, we can highlight or be very specific about which groups of muscles we're activating. And so that's the way that we can be very specific. We systematically looked through, different sort of metrics, the first one being isometric joint strength. In some cases, patients were able to produce twice as much or more force in certain joints. And I also want to highlight grip strength as well. This was really important for SCSO2, the second subject, who essentially couldn't move her hand at all when she came to us, and by the end was able to grasp objects and lift them of her own volition. We also looked at reaching dynamics. So these are kinematic plots of 2-dimensional reaching in the KinArm machine that you can see here, where patients are reaching out to different targets. You can see that without stimulation, movements are a lot less smooth. They're a lot slower. In some cases, can't even reach the target. And if you compare, especially for subject 2 here, you can see she's able to reach much further with the stimulation on. These look different because SCSO2 was much more impaired and couldn't actually perform the task on the top, but she still saw some improvement. I'll leave the rest of the results for you to look in at the paper. But I want to kind of switch gears a little bit to talk about how we actually implement this kind of technology as a company and as an industry. As we talk about these sort of bioelectronic medicine applications, there is going to need to be collaboration across the hospital ecosystem to help patients really benefit most from this. So that's something we're looking into a lot as a company, is how can we get, a stroke patient's neurologist, their physiatrist, their neurosurgeon, which is not typically, after the initial surgery someone who's involved in post-acute stroke care. How can we get these groups all to work together well? And there are some nice models actually nearby in Mount Sinai, for example, of exactly this type of thing that we're looking into, and see how we as a company can actually help promote those things. This is kind of a rehash of the numbers I showed you earlier. So again, 800,000 people have a stroke in the US every year. Half of them end up with permanent deficit. But very related to the talk we just heard, about a quarter of those patients with motor deficit we've identified as being optimal responders to our therapy. We think it's really important to identify early on who are going to be able to leverage this technology as best as possible. And in our case, we found that corticospinal tract intactness is a very good indicator of whether or not someone will respond well. So something we're looking into right now as part of our clinical studies is exactly how we can stratify patients in this way. Just to highlight our team, I think that really it's one of our biggest assets. I want to highlight in particular Professor Marco Capogrosso, one of our co-founders, whose entire academic career has been in spinal cord stimulation for movement impairment, specifically lower limb function, so walking in spinal cord injury patients. Doug Weber probably doesn't need much introduction in this audience, but he's a great asset to the team as well. 30 years of experience in the neuroengineering fields and former DARPA program manager. And then we also have a neurosurgeon on our team, and Jacques Deckers, who's a 2-time CEO in the neuromod space and a really great advisor to have. Just to tell you a little bit to wrap up about what Reach is doing as a company, we're working right now on building a system or a platform that is optimized for this type of therapy. But at the same time, we're actually still collecting clinical data. So the study that I showed you at the beginning of the talk is ongoing, and it's already been funded for the next 5 years. So we have a lot of really great data that's going to be coming in parallel to us developing this system. And by doing that, we're hoping to sort of speed up the pathway through the regulatory process as a company. And we can kind of collate the data that we get to kind of go straight through a final validation step, final clinical validation before we move on to a clinical trial or a pivotal trial. The last thing I want to do is take this opportunity to announce today that we recently received breakthrough device designation from the FDA. This is super exciting for us, obviously, and we're really looking forward to working closely with the FDA and really leveraging the advantages that this program provides to bring this technology to market. So with that, I'll wrap up. I will say that to any investors in the room, there are opportunities to join our journey. So please don't hesitate to reach out to me. And of course, if you have any questions, please share them.
All right. Whoops. Thank you very much, Mark. That was a great presentation. Would you be good enough to unshare your screen? So the next guy, of course, which is Chris. And Chris, feel free to share your screen now. Oh, and in that case, never mind. I'll open it up for questions. Yes, we have a question from Dan.
So, a quick clarification is after a period of time, is this curative, or like does neuroplasticity take over and you don't need the spinal cord stimulator anymore? Or is this sort of, you're going to live with it forever?
Yeah, it's a great question. So to be fair, we've tested this for 30 days so far as the longest we've had a patient implanted. But I will say is that after that 30 days, even a month later, we still saw retained benefit that those patients had, specifically in Fugl-Meyer scores. I say that not to say that this is something we can explant and the patient is cured, but more to say that there are plastic changes happening in the nervous system that we're looking into. My guess actually would be that we would likely have patients who want to keep this full time. And the reason is because we always saw an extra boost, even on top of stimulation off benefit from the beginning of the trial, when we turn the stimulation on, an immediate, what we call assistive effect, that likely will continue to be helpful for patients even after they've recovered a lot of the effect that they've seen.
Cool. I got one more quick follow-up. It's just sort of a engineer nerd question. Used to do spinal cord stim at St. Jude. Cervical space was a nightmare because of lead migration. Are you guys having to do anything special on that? Or I guess you're only doing 30 days, so the long-term data is not there, but just curious.
No, that's a great question. And it's part of what we're building into this system that I mentioned. So as a company, we're very aware of the challenge of implanting leads in the cervical spine. In the course of the 30-day study, we actually found that there was not significant lead migration. And that's because of sort of an anchoring technique that we've used and developed at the University of Pittsburgh. But building a lead that is really designed for the cervical spine is a critical milestone for the company because of exactly the challenges that you're mentioning.
All right. And it looks like we have one question from a Zoom participant. Do you want to unmute your mic and go ahead and ask your question?
Yeah, thank you. Thank you for the great presentation. So your approach looks quite similar to some of the work that's being done in spinal cord injury by companies like Onward Medical and Unwevo. Other than that, maybe the placement of the electrodes is different. Is that accurate? And are you considering expanding into spinal cord injury?
Yeah, thanks for that. And there's a good reason actually that these look similar. Marco Capagrosso did his PhD work in Gregor Cortin's lab and wanted to start a company or start a lab based on some of the work he did there. What I will mention is that there's a pretty distinct difference between lower limb function, like they're working on at Onward right now, and upper limb function, which is that in lower limb, you have spinal circuits, central pattern generators that create these very rhythmic movements of muscle activity to produce walking. In the case of upper limb, we weren't sure that that would translate very well because upper limb movements are the exact opposite of rhythmic or patterned in these complex movements that you have to do. So, there's that difference. Spinal cord injury absolutely is something we're interested in, but we're really focused right now on the stroke population. I think this is a group of people who are very much underserved by the healthcare system, and looking at chronic stroke as our primary focus is what we're doing for now.
Great. And we have time for one more question.
Thanks. Just a quick question. Not working? Okay. Just a quick question on it's an invasive procedure on a population that largely is rather elderly. Have your number calculations taken into account the fact that some of those people won't actually be able to take a chronic implant in the spine because of their frailty? And subsequently, have you looked at any of the non-invasive options that people seem to be talking about these days, sort of end limb type stimulation that's doing the same closed loop functionality, but from a slightly more distal position?
Mhm. Yeah, great question. So the number I put up there, the quarter of patients who could benefit most from this, does not take into account the people who wouldn't be indicated for surgery altogether. I do want to highlight that the stroke population actually has a very large proportion of people who are quite young. So 40% of all stroke patients are below the age of 65, but it's a great point that we'll need to consider that. And then you had one other question. Could you just remind me the second? Oh, non-invasive. Yeah. Yeah, so one of the benefits we have by targeting the epidural space is that we can be very, very specific with our stimulation. So we have sub-segment resolution, and that means I can help someone's ability to extend their arm without impacting their ability to flex their arm. And so we really see that specificity as a huge benefit of our, invasive technique. But that said, there's other companies that are showing great work in that space, and we'll keep an eye on them and see how things develop. But I think we really are happy with the amount of detail we can provide for our patients.
Okay, thank you very much, Mark.
Thanks.